psychoanalysis. And what does it cost, and who can afford it, and who is it available to? Almost nobody, except people with rich parents or with independently wealthy. So by and large, in psychotherapy's role in mental health services should be mostly brief therapies which have the strongest evidence behind them. Um, some people have tried to say there's evidence for complex disorders. Leixenring from Germany published a couple of meta-analyses about this. But these findings were entirely based on pre-post comparisons, had small effect size, did not compare shorter or longer term treatment. Our own model in Montreal is we offer brief therapy to most of the patients we see. We reserve longer treatment for those who do not respond. Or sometimes we do assign people to longer therapy if they're very chronic, and we're looking at a rehabilitation model rather than a standard therapy. So all therapies, of course, will work on emotion regulation and control of impulsivity and improve interpersonal relations, and they all have good ideas that can be integrated. So we are publishing an article. It's an effectiveness study. It's not a randomized controlled trial. There was no control group, but these are expensive studies to do, and this is a beginning. And the editor of the journal in which our paper will be published, which is Personality and Mental Health, is Peter Tyrer, who is well known in the field. And Peter wrote us and said, I had written in the NICE guidelines that borderline personality disorder should not be treated briefly, and now maybe I have to revise that, although obviously we need a lot more evidence. But I think our study was fairly unique. We had 479 patients in short-term therapy, which consisted of individual and group, which, as has been discussed before this conference, the combination is better than either alone. And we treat our patients in 12 weeks. Now, we do get a lot of dropouts. About 30% of patients accepted into the program will not complete it, and we don't know what happened to them. So nevertheless, if we help half or to two-thirds of those who come, and they're mostly these people coming through emergency rooms with the usual problems, we think we're doing all right. We're not asking for it to be successful with everybody. And only 12% of the patients who've completed the short-term program returned asking for more therapy later. It means 88% of them did not. I don't have any systematic follow-up of these people. I called up 50 of them at one point, but I haven't got any systematic data. Now, we did include a longer-term option, and which we offer to 145 patients. This is over 15 years, by the way, since 2001. And these patients can go up to 24 months, but we've come to think that that's too long. And so the average length of our extended care program is actually closer to a year. So it's still not 4 years of DBT or of an endless therapy. And basically, the findings of our effectiveness study was that symptoms went down remarkably and rapidly in both clinics, although we had a harder time with substance abuse, and substance abuse is the comorbidity that makes this personality disorder particularly difficult to treat. That's quite clear from other evidence. So our conclusion is that BPD can be treated briefly in most patients. There is no reason to follow a specific treatment model, and our concern is one of accessibility. And in Montreal, we've been able to also establish a network around the city and its suburbs in which most places now offer treatment for borderline personality disorder in specialized care. So there's about 6 or 7 hospitals in our area that are doing that. And this is publicly funded treatment. We have the advantage of publicly funded treatment in Canada, single-payer care. Unfortunately, things which are psychological or psychotherapeutic are not as well insured, not as well covered, as is the case other places. Nevertheless, we've been able to establish teams of psychologists, psychiatrists, and other mental health professionals to provide this treatment and to make it accessible so that the patients can come into treatment, most of them for the short-term program, within a couple of months. And so we think this provides rapid and accessible care for patients who represent a serious public health problem. So I've been very brief. I think maybe we'll take questions. We have enough time, since we only have 2 presentations. I'll take any questions you have at this point. Yes?
You said yesterday that the disorder has changed over the last 5 years. Can you speak more about that?
The perception, well, I think the disorder hasn't changed, but the perception of the disorder has changed. One of the reasons we were able to develop these programs was because we convinced the hospital administration that this could help to reduce the pressure in the emergency room, because the emergency rooms were flooded with these patients, and couldn't manage them. What I said yesterday was that the awareness movement for recognizing borderline personality disorder, for not misdiagnosing it as bipolar disorder or major depression. This situation has greatly improved. A lot of people have worked on this, including your organization, and so I think it's out there now, not as Ken Levy said, something to be dismissed as unscientific, but in fact has a big research program behind it. In fact, there are a couple of thousand research papers out there on borderline personality disorder right now, and that kind of help but have an impact, even if it's hard to get funding for research like this. Yes, sir.
Joel, just so I can stop your data clear in my mind, the brief talk of treatment is people are often irrespective of any measure of severity, so that's just an offering that people get. So there's no assessment of severity within that.
We take. I mean, there are. I think chronicity worries me more than severity. It is.
As is substance abuse, but I just want to get to your sense that they all are offered that, and it's their outcome of that then determines if they have longer treatment, which is only 12% that come forward with that.
Yes. Well.
Do you have any follow-up from the people who never come back?
We don't know about the people. We don't know about. Yeah, okay, to take the last part first, we don't know about that 88%, and what's happened to them. That would be very, very useful and important to find out. On the other hand, we don't think, given the high treatment-seeking behavior of this population, we think that most of them are doing, since most of them benefited from the short-term program, we think most of them are continuing to maintain those gains in the community, and are not necessarily seeking further therapy, or certainly not further specialized therapy. Most of the patients we take into the short-term program are young women. And so if somebody comes in their 50s with a 30-year history of personality disorder, and as often the evolution is that they start avoiding having any relationships, and they're chronically unemployed, that kind of patient is probably not very good for our 12-week program. We do best with young, hot patients. Some of them have made near fatal suicide attempts just a few weeks before we start treating them. So on that level of severity, we're not excluding anybody. I don't know if that answers your question, Anthony. Sort of. Okay. So let's move on to the second presentation.